people feel as though they're confused about the scoring of some of the tools and what are the best tools for care of kids with ADHD. So I've assembled a little slide deck here, and my disclosure is that some of this will be tools that exist in Chattis or available through Chattis. So we have a conflict of interest with that, but Dr. Frosch does not have any conflict of interest. So I think one of the things that we would want to be sure that people know is that a screening tool or a symptom assessment tool for ADHD is never enough to make a diagnosis of ADHD, nor is it enough to actually manage ADHD. These are just tools that help, and that it's always important to take a good history from the parent as well as the child, and get information from teachers. Often that's not really a history from teachers, although if you can do that, that's very helpful too. And that the diagnosis requires assessment of information from at least 2 settings, and that's where using a validated tool is often the most helpful, is getting information from teachers through a checklist, because you can't always talk to them. We should also always be thinking about looking for comorbid conditions, both in the initial diagnosis of ADHD and in the management, because sometimes what happens is the management fails because of the coexisting conditions. Even if you got the initial diagnosis right, other things are complicating your management. So we always want to know how well a patient is functioning academically, in terms of their social interactions, or if they're in a work environment, how they're doing, and to get academic records. Standardized psychoeducational testing and comprehensive neuropsychological testing are not necessary in every case, but if there are signs of a learning disability, and I always recommend doing some learning screening, as well as looking at the report cards and any testing the child has brought in. We always want to be prepared to send for psychoeducational and neuropsychological testing if necessary. And of course, knowing how the kid is actually managing in school. The administrative reports, like disciplinary actions, can be often gotten from the report card. But in addition to that, you find out about school absences. So those are a whole range of different kinds of information you might want, but I'm not going to talk about all of those today.
Barbara, can I just add one? Barbara, can I add one comment?
Yes.
Sometimes people come away with the idea thinking that neuropsych testing can make a diagnosis of ADHD, and it can be, as you said, very useful to understand strengths, weaknesses, learning disabilities, things like that. But neuropsychological testing does not make a diagnosis of ADHD. But often we hear families say, well, he was tested and he does have ADHD, or he was tested and he doesn't. And that is a nonsensical sentence. It can support a diagnosis, or it can be confusing with the diagnosis, but it is not, there is no test for it.
Good. I think that's a very important point. I would say the same thing about a pediatrician's observations in the same way. You can have an impression, but that doesn't make for the diagnosis. You have to have all of the different kinds of criteria. So today we're just talking about some other tools. And part of the reason I wanted to bring this up is because of the data that we know about the importance of getting feedback from other places, in particular teachers. So you may have heard of the multi-site multimodal treatment study, or the MTA study, which we've been leaning on for a long time, which was done with 600 kids from 7 to 9 years old who had ADHD combined type, and they looked at 24-month outcomes where they compared medical management that was tailored monthly with feedback from schools as well as from parents. There was only one medicine used in that study. It was methylphenidate. It compared it to a behavioral therapy that was pretty comprehensive. It had 8 weeks of summer intervention. It was training for parents. There was an in-class aid. There was teacher consultation. So that's great. That you'd be hard-pressed to ever get that kind of assistance for a kid nowadays. And then there was a combination of medical management and behavior therapy. And they compared this to community care, which is basically their control group, which is pediatricians managing kids the best they could. And most of the time, 67%, these kids were getting methylphenidate twice a day because that's what was available to them at the time. And this is just a summary. You can see that I've chopped it up a little bit just to show you. Sorry, let's see if the screen is on automatic advance. The control group, This is the percent that were normalized in symptoms, meaning the symptoms were below the cut score for ADHD. 25% of the community sample was versus 56% of the medical management group. So this difference, remember, same medicines, the difference was that there were dose adjustments based on school feedback. So that's really part of the argument for why it's so important to get, use some kind of standardized tool.
Out there, yeah. When you come out, go over there.
So while this study went on for 10 more years, what they found was that the differences between the groups became lower over time. But the other thing that was of note is that the medication group, which had been strictly managed with their medications, tended to use medicine less, and the behavior group tended to use medicine more. And in the end, 34% of the kids continued to improve on medication over 10 years, but you couldn't tell which ones they were going to be. So basically, we as clinicians need to have continuous relationships with these kids and treat it as a chronic condition in order to make sure that we're doing the best for each individual kid. But I wanted to talk about the Vanderbilt ADHD rating scale. Shirley, are you using the Vanderbilt there where you are?
The first edition. I have
First edition. So
second edition, yeah.
So you need to move up to the further editions because some important things have changed about it. So one of the things the main thing about the Vanderbilt that was a big help was that before that, all we basically had was the Connors, which had a cost to it and was pretty long. That was a long time ago now, so I'm going to show you some more updated tools. But the Vanderbilt is now widely used around the United States and apparently around the world, and it has both symptom ratings and impairment ratings. And that's really important because the official diagnosis of ADHD, as for all mental health disorders, is that there has to be some impairment. This also causes a huge amount of confusion in people who are using the Vanderbilt. So I'll explain why in a minute and what to do about it. So the symptom cutoffs are like the DSM-V symptom criteria. So you have to have at least 6 out of 9 symptoms in either inattention or hyperactive impulsive symptoms. So here's the inattention or hyperactive impulsive at the often or very often frequency. So not just a little bit, it has to be often or very often. Or for the combined presentation, you can have more than 6 or more than greater than or equal to 6 out of 9 on both of those. And then in addition, the other advantage of the Vanderbilt is that it begins to look at comorbid conditions. And the comorbid conditions can be problems by themselves, whether the kid has ADHD or not, but they are the most common things that run along with ADHD, and they include oppositional defiant disorder, conduct disorder, and anxiety or depression. So these are actually 4 things, not 3 things, because they aren't the same. Here is what you need to know about the most current Vanderbilt, and that is, for the oppositional defiant disorder screen, you need at least 4 out of the 8 symptoms on the parent version, but you only need 3 out of the 10 items on the teacher version. And those have to be scored at the often or very often. So the parent and teacher scoring is not the same. The parent version also has conduct items, which the teacher version does not. And you need to have 3 or more of the 14 conduct items scored at often or very often to have a positive conduct screen. The anxiety depression items, you need at least 3 out of 7 rated as often or very often. So it's a little bit complicated. And what happens is people tend to use the Vanderbilt. They just scan their eyes down to see which things have been circled farther to the right. And if there's a lot of them, they say that's ADHD or I need to treat it. Well, that's better than using nothing, but it's not the official way the Vanderbilt is scored or validated based on actual tests against more gold standard tools. Now, for people who are using Chattis, we have a graphic display where you can see, the inattention bars vertical, the hyperactive bar vertical. The yellows and reds constitute the very often or often, and they float to the bottom. So any that are above the cut line here, see there's 5. So any yellows or reds above that would be 6 or more. So that makes it easy at a glance to see about symptoms that are of significance. And then the horizontal bars are the impact. And as you can see, for the parent, we've got parents, siblings, peers, and activities for impact. And over here, for teachers, we have peers, directions, disruptions, assignments, and organization for impact, because we don't expect the teacher to be able to judge some of those other things. You can see over time the same parent dose of medicine was entered into Chattis by the parent, and you can see the teacher's scores at different dates as well. So this is a graphic display that's useful for getting a quick impression. However, it doesn't tell you whether it has passed, whether it has come up with the official cut scores for the Vanderbilt or not. And Shirley, you were mentioning you're using an old version. The new version is based on the Vanderbilt, adjusted for DSM-V with research-based changes. So I'm going to tell you about this different set of research-based changes for the Vanderbilt. So the first one is that in the DSM-V now, you can have symptoms with onset before age 12, not age 7. So it used to be age 7, now it's age 12. So that's one big difference. Then there's a difference in the impact scoring. It used to be that any one behavior or achievement item, which was somewhat problematic or problematic, would count as adequate impact to be considered significant. Now, in the new version, what Woolrich found was that you really needed 2 of the somewhat problematic or 1 of the problematic to be considered significant. So that's a big difference in the way this thing is scored. And then there's also a new score called the total symptom score, which may not have been so obvious before, but the important thing to know is that this is not an add-up of the scored items. This is actually the number of symptom items out of those 18, 9 inattentive, 9 hyperactive impulsive, that were scored as a 2 or a 3. So it's not an addition of the items, and there was a lot of confusion about that. So the value of this is that you can, at a glance, have a single number to track over time to see how the symptoms are coming along as a whole. So that's really the point of the Vanderbilt Total Symptom Score. The other thing that's changed, another thing I should say that's changed, is that adolescent scoring has been clarified. So we know that adolescents and adults can have ADHD, but the symptoms may not be as frequent or in as many categories as it is for children, but they still have significant ADHD. In fact, only about 1/3 of patients have no significant ADHD symptom as adults if they had it as a child. So now, if the kid is over age 17, the criteria for symptoms drops from 6 out of 9 to 5 out of 9 needed to reach symptom cut scores. So that was another change to adjust for age. Another thing that changed about the Vanderbilt is that the DSM they've added in consistency with the DSM-V a stolen while confronting a victim item. Now, you still only need the same number of conduct items, which is 4 or more for parents, right? But the scoring is unchanged. So it's just that this can contribute to the score to meet criteria, but the fact that there is 1 more item doesn't change anything else. Okay? All right. Now, we've changed a few things about the way we demonstrate the Vanderbilt in Chattis. For one thing, we're showing the total score, which I discussed. The other thing we've added is in accord with what the DSM-V wants us to do and what the AAP recommendations are, which is that you should look at symptoms at different times of day, okay? Because in order to fulfill the guidelines, AAP guidelines, you want to know what the duration of the treatment effect is, because you may be getting information from parents when they're seeing the kid unmedicated versus the teachers who's seeing the kid medicated, for example. And children may act differently before the medication has started or after it's stopped, or if they're tired, so it's worse in the morning, for example, or it may be worse at certain classes of the day because they have a learning problem in that class. So that's why it's really important to know what time the teacher is judging the symptoms. Now, on the official Vanderbilt forms, it asks what time of day the class is. So we've added that into Chattis as well. And
you added a part where it asks at what time of day are the symptoms worse and what are those symptoms. So even if it's the same teacher all day long, the duration is extremely important if you're trying to provide long-acting medication, because even though the package may say 12 hours, in the kid it may only last 5 hours. So
I think that's a really important point. I think it's also important to know what subject the youngster is taking when they may have a flare of symptoms.
Exactly.
It may be that they are having a flare because they can't pay attention, because they don't understand, because they have a learning disability. Most kids would rather be naughty than dumb, and so they will perhaps look more off task or be disruptive if it's a subject that is more challenging for them. So it may not be that their ADHD meds are wearing off, or there's some other ADHD specific problem. It may be a clue that something else is going on.
Yes, that's what. Yes, as Barbara said, also that's the differential. Is it the subject moment or the medication, and that's for you to sort out. And
right. Let me add one thing to that. Some teachers are more tolerant of ADHD symptoms than others. So sometimes they're acting up according to that teacher checklist because the teacher actually doesn't like kids who are wiggling, or can't stand kids who are raising their hand all the time or talking behind their backs. So it's very, very useful information to know what time this is happening as well as what subject. So hopefully that will be helpful. Shirley, any questions about the Vanderbilt here before we go on to talk about some of the other tools? Or Emily, do you use the Vanderbilt at all for monitoring kids?
Yeah, in the outpatient world, we absolutely use the Vanderbilt. The inpatient world, which again is not the standard garden variety ADHD, they are using something called SNAP, which is a more behavioral observation tool in real time, rather than the Vanderbilt. But absolutely, people use the Vanderbilt in practice quite standardly.
Very good. What was the name of that inpatient one?
It's SNAP, SNAP.
Oh,
I don't remember what it stands for.
Yeah, I'm going to show you that in just a second here on the screen. But yeah, that's good. I'm glad to know that that's true.
So recently, and recently as of last week, there was a report on the adolescent version of the Vanderbilt. Are you going to talk about that?
Well, I thought I'd say something, but yes, in a bit. But actually, it was really interesting how it came out, because what they found was that when adolescents self-reported, and they did a wonderful study, you know, they compared it to multiple other measures, and what they found was that if you had, because adolescents were not very self-aware of their ADHD, if they had a score of 1 or more, that was the cut. Oh, on one item.
Practically, yeah, but
not very useful.
So lots of pediatricians, and we all want to get the adolescent. Why don't we have an adolescent report? And that's because I think it's been even before that well known that they underestimate their symptoms. But it's of value to engage them in the process. So it's a welcome that. So what they did is they changed the words, but then they had to change the score to make it sensitive to any other external criteria.
And then it wasn't very useful because it's only one. Okay, well let's just talk about some of the other tools. So one of the ones you may have heard of is the Connors, which has been around really the longest of anything. And Keith Connors, who's at Duke, friend of ours, actually made a huge contribution by creating this score. So he's modified it a lot since then, and some of the new forms are available. And it's basically got a couple different parts. The new symptom scales have been adjusted for the DSM-V, and then there are also some content scales that break out of it, which include the more familiar inattention and hyperactivity, but also include learning, executive functioning, defiance, aggression, and peer and family relationships. So those are the pieces of the Connors. And there's now all of these different forms. So there's a Connors parent, both a full, 108 items, and short, 27 items for ages 6 to 18. There's a teacher one, same age group. Self-report, same age group, long and short. There's a global index, which can be used for following kids over time. And he's actually broken out 10-item screener, which he calls the ADHD index. And these can be done online, on paper, or by email. And then there's some scoring functionality that's available through the publishing house, which is Multi-Health Systems, a quick score or a full score. There's also an online portal, and you can use either the DSM-4 TR version scoring or the DSM-5 scoring. So those are lots of different forms of this tool. And Connors is also available through Chattis as well. Now, the reliability has been pretty good. Internal consistency is about between 0.7 and 0.9. Inter-rater reliability, 0.5 to 0.9. And it has been analyzed by factor analytic techniques and confirmatory samples against related measures, and shown to be able to differentiate kids with ADHD from the general population, and also to distinguish it from disruptive behavior disorders and learning disabilities. So it's a good tool. It's long and it's fairly expensive. There are norms for males and females in 1-year intervals. It was normed on about 3,400 kids with 50 boys and 50 girls at each age, and a decent racial ethnic distribution. So a nicely designed tool. So that's one tool. Then there is a tool called the Swan, and we have some positive feelings about the Swan, because Swan stands for Strengths and Weaknesses of ADHD Symptoms and Normal Behavior Rating Scale. So basically, it gives a range of scores that include being good at paying attention, being good at controlling your impulsivity, not just being bad at it. So that's kind of a more positive spin on things, which is something we like. It's now been revised to DSM-5 criteria. Basically, it's a revised version of the SNAP, which is what Emily was talking about.
The S is for Swanson.
And well,
Dr. Swanson.
the S in this is Swanson. The S in this is strength. So it's two different things. And they changed the wording to adapt for positive attention and impulse regulation. As I mentioned, psychometrically, it's the same in terms of the distribution of individuals, and it does discriminate between children with and without ADHD and predict subtypes. So that's a good thing. Here it is, right here. Here are the 18 items of the Swan, and as you can see, you can have not at all, just a little, quite a bit, and very much. So it gives you a chance to rate these things, and this is really basically a doable tool. And it's only fairly recently been released because he was waiting for more psychometric data. So that one's available for use. Then there's something called the ADHD Rating Scale version 5. Now this is the old DuPaul, which you may have heard of before, D-U, capital P-A-U-L. Also done with a guy named Tom Powers from Philadelphia, CHOP. And there's a home and a school version of this. Again, 9 inattention and 9 hyperactive symptoms, just as you would expect. There's an adolescent self-report form, which is of value. And one of the things I really like about this scale is that it includes 6 different domains of impairment. So that impairment scale on the Vanderbilt's kind of a pain for the following reason, because it asks about it asks about performance in terms of learning, like grades. Well, 45% of kids with ADHD have a learning disability, and sometimes, and a lot of kids have learning disabilities without ADHD, the learning disability or lack thereof can make the difference in whether the Vanderbilt is actually considered to be positive or not. But it's a little biased because of that complication with learning disabilities. So this tool, the ADHD rating scale, ranks impairment in relationship with significant others, meaning at home, peer relationships, academic functioning, behavior functioning, homework performance, and self-esteem. And the impairment is rated 2 times, once after you do the inattention items and once after you do the hyperactive items. So those symptoms can be impactful in different ways. So there's 2 different forms, one for 5 to 10-year-olds and one for 11 to 17-year-olds. So it goes down a little bit lower than the Vanderbilt, which was, and actually that form of the Connors. I didn't mention the fact that there's also child behavior checklists, which can be used in younger kids too. I'll mention the preschool scale in a minute. So it was normed with about 2,000 parents, and the scoring templates, which are percentile based, are also gender and age adjusted, which again, the Vanderbilt is not gender adjusted. Emily, do you want to comment on gender adjustment of ADHD symptoms? What do you think about that?
I think there's a little bit more awareness, but certainly historically, girls were not necessarily thought to have it as frequently, sometimes because they present more with the inattentive type. The hyperactivity and impulsive version is much more easily recognized, which may be more common in boys. I think those gender stereotypes are waning in people's awareness of how to think about ADHD, but it's something to be mindful of. Teachers and families may have different expectations for different genders, though, and that becomes relevant when taking a history and trying to make sense out of reporting.
Yep, makes sense to me.
Yeah, and when you take a look at these, what Swanson has done, and the Vanderbilt, Connors, and DuPaul ADHD ones, there's a difference between whether you're trying to conform to the DSM-V definition, and they say it's not an accident they all have 9 items. Well, because that's what the DSM-V has. On the other hand, what Dr. Swanson's done is to say, well, ADHD is kind of a dimension. Everybody has attention to one degree or another, and so we should not look at the definitions per se, but you could look at how deviant or how different you are from the normative sample. And then you'd look within girls, and so it looks like Connors is doing it kind of both ways, because what matters is, statistically, are you 1 or 2 standard deviations, or do you meet the definition, which is one that doesn't take into account gender, although some, as Emily said, some of these things are not as well recognized across gender. So there's different perspectives on what it is, and there are also some data now, and very recent, especially in kids who are sub-threshold for the DSM-V diagnosis, and those kids, when you follow it carefully, if they're just below the cut, they actually 3 years later do as badly as the kids who were just above the cut. So the criteria are important for getting paid and making formal diagnoses, but also I think we're learning and understanding a little more about paying attention to the temperamental tendencies of people and how it matches up with their context and cultural expectations. So it's that's where we are. Is it a category or is it a dimension?
Right. But when you're working on trying to adjust medication, you're really interested in the symptoms because you presumably already made an accurate diagnosis based on category, and then you're trying to control the symptoms the best you can. So another tool that has a long history is the SNAP. That's part of the one that Emily was talking about, Swanson, Nolan, and Pelham, which is now upgraded to DSM-V criteria. It's 90 items, so it's long. It does discriminate kids with and without ADHD and accurately predicts the specifiers of inattention, hyperactive, and combined. It also has a lot more items in it for the differential diagnosis and for other DSM-V disorders, and that's part of what's valuable about it. It's normed on over 1,000 kids. It includes the 10 items of the SCAMP to gauge severity of impairment in the classroom. The SCAMP is the one you've probably seen on all those pharmaceutical brochures as the observation measure that people are using to determine if a medication is working or not. It also collects criteria for oppositional defiant disorder and has a general index for childhood problems. And this slide shows the comorbidity items. Now, there's not a lot of items for each one. So it's got conduct, intermittent explosive disorder, stereotypic movement disorder, obsessive compulsive disorder, generalized anxiety, narcolepsy. I was interested that they put narcolepsy in there. Adjustment disorder, histrionic personality disorder, narcissistic personality disorder, borderline personality disorder, 1 item each, as though you could really diagnose it from that, which you can't, of course. Manic episode, which I particularly like included in this tool. And the reason I like it is that one of the problems we're having nowadays, and we talked about this previously at another session, is differentiating kids who may have bipolar disorder from kids with ADHD, particularly if you're dealing with an older kid who may say they had symptoms before age 12, but now you're dealing with them and they're 14, and you want to make sure that they don't have bipolar disorder, and that's not such an easy thing for a pediatrician to do. So having items about manic episodes can be helpful for that. Also has dysthymic and PTSD items. But as you can see, there's only 1 or 2 items for each one, so you can't actually make those diagnoses based on those items, but it may point you towards the need for further evaluation. So that's a reason to like that tool. And then I want to tell you about a tool that I've just recently become aware of called the ADHD Preschool 5, which is a DSM-V tool for kids 3 to 5 years old. So the items have been adjusted for the younger age group. So it's giving examples like learning your ABCs rather than, you know, doing your homework independently, which is more appropriate for an older kid. It's 18 items, and they are alternate between attention and hyperactivity. So the first one is fails to give close attention to details, and it rushes through activities, makes careless mistakes. And then the next one is hyperactive, fidgets with hands or feet, or squirms in seat, taps hands or feet. So it's similar in that way. It actually was done very nicely with its validation with over 900 parents and 900 teachers with a range of ages, but slightly oversampled higher socioeconomic class parents, which is a little bit of a problem. It converts to T-scores and gives you percentile ranks and has reliability coefficients between 0.8 and 0.95 in validation against the Connors. So that's how it was done. But it's nice to have a tool that's actually been validated on younger kids. Now, just to say that, you have to be careful about diagnosing in preschoolers. And we had another session at another time. There's a recording on Chattis website about thinking about preschool is a separate issue where you have to be much more careful. And again, this is not a diagnostic tool, but if you are in fact trying to follow a kid who you've properly diagnosed with ADHD at this age, here's a tool that you can use that will seem more appropriate to the parents and the teachers. And here's the scoring. As I said, it has different scoring for boys versus girls. And then I want to mention the Adult ADHD Self-Report Scale. Now, this is intended for individuals 18 or older, but it's something to think about for some of your older adolescents where the Vanderbilt doesn't seem to capture it, because these are real examples that an older person would be able to endorse. And as you can see, it's not that long. This one's also available in Chattis. So the key diagnostic items are the ones in items 1 through 6. So if I go back here, you'll recognize 1 through 6 are dealing with details of a project, getting things in order, remembering appointments, doing things that require a lot of mental concentration, fidgeting, squirming, overly active, careless mistakes. That's 6? Yeah, I think that's 6. So those should look really familiar to you because they're similar to the ones we use for school-age kids. And it also gives you an other significant symptoms of ADHD score, which I think is valuable because the older individuals are, as we said before, they tend to have fewer symptoms, even if the symptoms are disabling for them. Want to comment on that?
Just a report to us.
Right.
Yeah. It's nice that it doesn't require a school setting.
Right, because you don't have a school setting and you don't want to ask your boss to rate you on your ADHD symptoms. Emily, do you want to comment on adolescents and older young adults that you might be dealing with and whether there's tools that you like for that?
Yeah, we don't necessarily have any specific tool that we use. I think the history becomes even more important and more nuanced as the kids get older. I think also anticipating how adolescents want to transition from high school if they're going to go to college, and how they want to use the stimulants and their medication and what their peers may be doing with the same medication, which may be different than what they want to be doing with it. And I think there's a lot of anticipatory guidance that PCTs need to do with families and young people as they're making that developmental transition with a controlled substance.
Yep, absolutely. That's really another subject all in itself, but one of the nice things about using a tool is that sometimes a spouse may not know what they're dealing with, and having a tool that describes some of these behaviors that are very annoying to the parent or the spouse or to the young adult themselves, and realizing that these may be symptoms of ADHD, I think can help them feel as though you're taking a more structured approach to it. So I think
the other thing I would say, Barbara, is that there are people who, because they're very bright, have been able to be quite successful throughout their schooling and life, but as they achieve at a higher level, they may be having more trouble juggling all of the things. And sometimes that's when you're going to make a first diagnosis of ADHD, by taking a thorough history and what they were able to do in the past, even though they never took medicine or anything prior to that. And sometimes that can be very powerful, so that the person doesn't feel like they're stupid or unable or, what's wrong with them, but to be able to show them the list of symptoms that they're struggling with, that those exist as an entity, and just because they were so smart that they were able to be successful without it in their earlier schooling years, it can be helpful to make sense out of the frustrations that they may be experiencing in their occupation.
Yes, I appreciate that perspective a lot. And of course, we're always watching for comorbid conditions like depression emerging, but depression can come from feeling so frustrated that suddenly your life feels like it's falling apart because you're
in a vulnerable person, right? Not in everybody, but in somebody who might be vulnerable to developing an affective illness, that can absolutely be a precipitating factor.
Yep, absolutely. So the last thing I wanted to show everybody is actually something we built into Chattis, which we call the DSM-PC5 modules, because what we've done is we've taken the DSM-5 and the primary care version of the DSM-5 that makes variation and problem diagnoses as well as disorder diagnoses, and we've created modules that are algorithmic. They're based on the logic of the DSM-5, so you do as few or as many as necessary to either reach criteria or be dismissed from criteria based on parent report, and we've made them for ADHD, mood, anxiety, and conduct. They can also be used separately. The benefit of this is that, again, looking for comorbid conditions is really important. Now, Shirley, all by herself over there in Indonesia, may have some of the same problems that we have as consultants, and that is we get the more severely affected kids. And so comorbidity really has to be on our minds a great deal, probably more than for the general pediatrician. But still, looking for comorbid conditions is important, as I said at the beginning, not only in the differential diagnosis of whether you've got the ADHD diagnosis correct, but also emerging over time, particularly if there's apparent treatment failure. So what we did was, first we did focus groups with experts and parents to check the wording, which is something that isn't always done with tools. And then we got parents of children between ages 4 and 12 who were getting care for their kid, either for ADHD or who had had a positive pediatric symptom checklist, to try to sample for these kids with ADHD and other conditions. And then they did these modules as well as the child behavior checklist, which I haven't focused on here, and I probably should have included the child behavior checklist because it's got versions that go down to 18 months and it's got an inattentive and hyperactive components to it. It's also been upgraded to the DSM-5. And then the parents all got an interview, which was considered a gold standard interview. So for the kids from 4 to 7, we used something called the DIPA, which was upgraded to DSM-5 for the conditions of ADHD, oppositional defiant disorder, conduct, depression, anxiety, or the mini kid also upgraded to age 5 for
DSM-5.
DSM-5, sorry, for 8 to 12-year-olds. So this is the data from that research, and this will be available in the recording, Emily, if you're interested in looking at it and can't see it right now. But when looking at the ADHD module itself, the DSM-PC5, that's the Chattis version, had sensitivity and specificity that were much better than the CBCL. The sensitivity was 0.67 versus 0.26 on the same patients, and the specificity was 0.92 versus 0.99, with a positive predictive value of 0.77 or 0.89 in the case of the CBCL. Now, those were important differences. That was for the younger kids. For the older kids, it was even more dramatic, where the sensitivity was 0.62 and the sensitivity of the CBCL was only 0.19. Now, for anxiety, there was also a significant difference with favoring the DSM-PC5 of 0.68 and 0.80 sensitivity and specificity for younger kids, 0.72 and 0.78, compared to the CBCL of only 0.27 for sensitivity for anxiety. Now, for we didn't have enough kids with mood disorders for the mood to be significant, oppositional or conduct to be significant. So, but the trend was there in the direction of this being a very useful tool. So our conclusions are the test-retest reliability was 0.66, which was good for recognition of any disorder. And as I showed you, it had high sensitivity and good specificity in identifying any mental health disorder. It was actually more sensitive but less specific or equivalent with the equivalent PPV, positive predictive value, for the CBCL. Then for specific disorders, our tool tended to be more sensitive, as I said, with the CBCL for both ADHD and anxiety at both ages, but the CBCL was more specific at younger ages. So adding this DSM-PC problem level diagnoses, remember this is based on not just disorder, which is what all of DSM-5 is, disorder. This allows you to have kids who have significant impairment from symptoms but don't meet criteria for disorder. That's the definition of problem level according to the DSM-PC. This actually improved the sensitivity for both the younger and the older kids, 0.98 and 0.97, but with lower specificity and still significant positive predictive value.
I just want to add a couple things. First, that the sample was all from primary care pediatrics. It was the kids they were seeing at checkup visits who had the problems, the pediatric symptom checklist of positive attention scale, or were being seen for ADHD.
If I'm not here, I'll leave you.
More generalizable that way. I think that the DSM-PC for primary care may not be recognized by many people these days. And it was something that it came about from a combination of the American Academy of Pediatrics with input from the APA, the psychologist, and the child psychiatrist, with an idea that this is kind of a compromise. We talked about the dimensional, that like for ADHD is really a dimension that everybody has, but then there's the disorder cutoff. But this one says, you know, there may be somebody who doesn't meet full criteria for the disorder, but it's impacting on them, and they have symptoms, and we can acknowledge it with a problem level diagnosis. And then there are others that parents are worried, but they don't meet any criteria at all. And we could acknowledge a discussion about that, because that would be a warranted thing in primary care by saying that's a variation. So we're trying to keep that classification system alive with a tool that also allows you to document clearly the criteria for each of the diagnoses, like for not only ADHD, but anxiety, mood, and conduct. So that, of course, that's from a parent perspective. You have to review it, but we're leveraging a lot of parent effort to go through all the criteria, which sometimes they make you do, but you don't want to have that impact on your clinical time with the family. So anyhow.
Great. So we're about out of time here.